So Timbuktu, Ghana, Mali, Zumanguru, you know what you're shown. Where what you're shown. So Timbuktu, Ghana, Mali, Zumanguru, you know what you're shown. Manchetaki, you know Zumanguru, you know where you're shown. You know, Bamasa, you know, Yasan, you know what you're shown. Get your Israel, get your Ethiopia, get Sudan, what you're shown. Abaka, you know, one year, I for Karaja, I got you 1 year, and a young fan. Abaka, you know, 1 year, I for Karaja, I got you 1 year, and a young fan.
Welcome to BWF Solicitors, a trusted and experienced family law firm specializing in immigration and naturalization, as well as dispute resolution. Meet Bernard Owusu, our esteemed senior partner with over 30 years of experience and known for his expertise and dedication to serving our clients and the community. BWF Solicitors stand for integrity, respect, excellence, teamwork, diversity and inclusion, and service to the community. We provide tailored assistance across all areas of UK and Ghana law. At BWF Solicitors, every day is filled with dedication, creativity, and a commitment to finding the best solutions for our clients. Led by experienced senior partner Bernard Owusu, the team at BWF Solicitors is ready to assist you with your immigration, naturalization, dispute resolution, family law, new wills and probate, Ghana law and practice needs. We are dedicated to providing solutions to our clients' problems. You can find us at the 4th floor, Anna House, 214 to 218 High Road, Seven Sisters, London, N15 4NP. Main office line 0208 493 7340 or our emergency line 07712 761 884.
Good evening. Welcome to tonight's edition of the Ghanaian Community Awareness Forum in partnership with Ghana Union, Ghana Nurses Association, and Western Region Association of Nurses. We bring to you tonight education, awareness, and engagement with you on issues affecting most of our community members in the UK and, of course, around the world. The issue of hypertension and stroke, its management, causes, symptoms, and treatment. These are silent killers, and before you realize you are in a different part of the world if you don't take care of it. So tonight we have some of our own experienced people, individuals who, through their field of work, are volunteering this 2-hour session with us to share with us some of the things that they've come across or they know of, and help all of us to manage circumstances of this nature much more better. Tonight's program is being televised on Zoom, YouTube, and of course Omega Live, and is brought to you by Ghana Union and Ghana Nurses Association. Without much ado, I'll bring to you our experts, our panelists for tonight, 2 key individuals who are in the field of care. In the name of Ms. Adjoa Ajay Bonahini, a member of the Ghana Nurses Association, I believe one of the executive members, and of course our very own Doris Beggar, who is an emergency nurse practitioner. Adjoa is also a nurse practitioner within the NHS. Tonight, I'm pleased to have you, and as always, you make us proud, and I'm sure tonight will be one of the exceptions. Thank you very much. Any of you who is ready to take over, please unmute yourself and you can take over for me.
Good evening, everybody. Our first presentation is going to be on hypertension. So I'm going to proceed. Hypertension. My name is Adjoa Ajabenhini. I'm a registered nurse and a practice nurse. I work in a GP surgery in Southwest London, and the surgery has about 15,000 patients. This session aims to improve your understanding and awareness of hypertension. Please can you wait to the end of the session to ask questions? You should be able to define hypertension and also identify lifestyle modifications that can reduce your risk of hypertension or allow it to get well-controlled hypertension. I'll give a definition and brief background. I will explain how hypertension is diagnosed, give contribution risk factors, also identify treatment and lifestyle modifications, the investigations that you would have around the time of being diagnosed, and sometimes further ongoing monitoring, and also the complications of hypertension. Hypertension, also known as high blood pressure, raised blood pressure, is a condition in which the blood vessels have a persistently raised pressure. This puts extra strain on your heart.
Sorry, can you share your screen with us?
Oh, sorry.
Thank you.
Sorry. Oh, I do apologize.
No, it's fine. It's okay.
Sorry, can everybody see that screen
Yes.
now?
It's
All
all
right.
good. Yeah.
All
Okay.
right. Sorry, I'll just recap back one. All right. So just to say that during the session, I will explain about the definition and background, diagnosis, contributing risk factors to hypertension, its treatment, lifestyle modification, investigations that you would have around the time of diagnosis and should be included on ongoing monitoring, and the complications of hypertension. So as I'll just recap. Hypertension is also known as high blood pressure or raised blood pressure. It's a condition in which the blood vessels have a persistently raised pressure. This puts extra strain on your heart and blood vessels. It's estimated that worldwide, 1.28 billion people between the age of 39 and 79 have hypertension. And I believe that's people that are diagnosed with hypertension. There's probably as many that are not diagnosed. Right. Most people do not actually experience symptoms if they have hypertension, but symptoms can include severe headaches, chest pain, blurred vision or visual disturbances, dizziness, palpitation, confusion, nosebleeds, sometimes sweating as well. Symptoms usually occur when the blood pressure is very raised. So that's 180 over 120 or more. You can, although get symptoms at a lower level, but it's often not. Right. Diagnosis. You would be diagnosed with hypertension if when you went to a surgery or a healthcare setting and your blood pressure was found to be 140 over 90 or higher. They wouldn't diagnose you on that one reading. What would happen is you would either be referred for ambulatory blood pressure monitoring or advised to have do home blood pressure monitoring, which I will explain on a later slide. And if your average blood pressure was found to be 135 over 85 or higher, then you would be diagnosed with hypertension. Most people tend to have essential hypertension, where the cause is unknown, but there's also secondary hypertension, which the high blood pressure occurs as a result of renal disease, endocrine disease, pregnancy. Right. So hypertension, as I've said previously, is diagnosed when your blood pressure is found to be 140 over 90 or higher. The 140 is the top number, known as the systolic blood pressure. So that's there. The 90 is the bottom number, known as the diastolic blood pressure. So if like the top numbers above 140 when you're in a healthcare setting, and the bottom numbers above 90 and or, then you'd have to have consecutive readings. And then if those again were, or you'd have to do the home blood pressure monitoring or the ambulatory blood pressure monitoring. And then if those were found to be above 100, so the top number with the home blood pressure monitoring, if it was found to be above 135, and the bottom number, as I don't know if you can see me pointing the arrow, is found to be above 85, then you would be diagnosed with hypertension. Right, so to explain ambulatory blood pressure monitoring, this can be done in a GP surgery. Some pharmacies do it, or an outpatients department in a hospital. Ambulatory blood pressure monitoring is when your blood pressure is measured as you move around, living your normal daily life. It's measured for up to 24 hours, and the blood pressure is taken automatically every 30 to 60 minutes. So you'd go to either a pharmacy, GP surgery, outpatients department of hospital. They fit the cuff around your upper arm, and then you have like a little carry machine, and then as you do everything, including sleep, it will take your blood pressure about every 30 minutes. It tends to be every 60 minutes whilst you're sleeping. You're advised, for the day that you have it, you're advised not to drive. Yeah. Next slide. Home blood pressure monitoring, which is also used to confirm a diagnosis of hypertension, is where you, as the person who's been told you might have hypertension, you purchase a machine and then you record your blood pressure, or maybe you could borrow one from a family member, colleague. You record your blood pressure morning and evening for at least, ideally 7 days, but at least 4. Then the average value of all the measurements are taken. If the average value is above 135 over 85, you would be diagnosed with hypertension. And you're supposed to, when you've done the 7 days readings, you can either usually email, text, write them down and take them to your GP surgery. And they do tend to be put on your medical records. This sort of demonstrates kind of how blood pressure is measured. And if you have a machine at home, you should kind of follow this. If you're buying a machine, they advise it's best to buy a machine where the cuff fits around the upper arm. Sometimes you can get wrist machines, but they're thought not to be as accurate. And you can buy them pharmacies, I think a lot of supermarkets now. You can also buy them online on Amazon, and the prices range from about 20 to about 100, but the cheaper ones aren't necessarily worse. They're just as long as it's validated, then it's fine. You should be sitting down in a relaxed position for about 5 minutes. So this is the cuff, and then that's the blood pressure machine. Have your arm resting on a table. So the cuff is at about heart level. So that's kind of the level that it should be. You just press, I can't actually enlarge that. You just press the button, keep still and quiet, and then the machine will take the reading. Avoid eating, exercise, smoking, taking medications for 30 minutes before taking the reading, as they can temporarily increase the blood pressure. Right. If you were to be diagnosed with high blood pressure, they would advise some investigations, and what they're kind of looking for is to see if the high blood pressure, which could have been present for some time, has had an effect on some of your body organs, particularly the heart and kidneys and eyes. So an ECG may be ordered, which is called, I should have wrote that, is electrocardiogram. And that would look, that can look at your heart rhythm, and it can also give a kind of an idea of the structure of your heart. It doesn't give an actual picture, but it can give an idea of the structure. And what they'd be looking for is any abnormal heart rhythms or signs of an enlarged heart. A urine test, so you'd pass like urine into a bottle, and then it could be tested at the surgery where they'd be looking for protein, or it may be sent away to a lab where they'd be looking for a specific protein. And both, if that's present, both of those could be a sign that your kidneys are damaged. They would order a blood test, which would involve screening for diabetes, again, looking at your kidney function and also looking at your cholesterol. The doctor at the surgery may look into your eyes with an ophthalmoscope, and they're looking for eye disease as a result of high blood pressure. Right, as I said earlier, in a few cases, high blood pressure can be caused, but can be secondary to having another health condition. Diabetes, kidney disease, sleep apnea, thyroid disease, whether underactive or overactive, lupus, and scleroderma. The risk factors for high blood pressure can be split into two categories: non-modifiable, which is basically things that won't change, or modifiable are things that can be changed. So the non-modifiable risk factors are age. So hypertension tends to be more common as you are in the age of over 40s. Ethnicity is more common in Black African and Black Caribbean populations. Gender, more common in men up to the age of 65, than over the age of 65, it's more common in women. Okay. And genetics. The modifiable risk factors are the things that can be changed are excess dietary salt intake, smoking, poor diet and obesity, excess alcohol consumption, lack of physical activity, mental health and stress, deprivation, and socio-economic status. Just to say a little bit more on the ethnicity. So I've said hypertension is more common in Black African and Black Caribbean people. It can occur at a younger age and in a more severe form. Worldwide, the African region has a prevalence of hypertension of around 27%. The treatment for hypertension is lifestyle modification and drug treatment. I'll probably concentrate more on the lifestyle modification, but I will mention a few medicines that you are likely to be offered an informed decision to take if you're found to have hypertension. Yeah, that's it. So hopefully this might explain a kind of the rationale over which, say like your treatment may be offered. So if your blood pressure is in the surgery is found to be 140, the top number between 140 and 159, and the bottom number between 90 and 99, you would be offered lifestyle advice, which I will explain later, and discuss the possibility of drug treatment. You may be offered drug treatment at that point in time as well. If your blood pressure in the surgery is found to be the top number, systolic blood pressure, so that's what SBP means, 160, between 160 and 170, and the bottom number between 100 and 119, you would be offered lifestyle modification and drug treatment. If it was found to be the systolic blood pressure greater than 180, so that's the top number, 180, and the diastolic blood pressure, the bottom number, greater than 120, you're likely to have a same-day hospital referral, because that would be stage 3 hypertension or hypertension crisis. Right, the drug treatment falls into, they usually say in sort of primary care, it's usually A, C, or D, which should be offered. A stands for ACE or ARB, which is angiotensin converting enzyme inhibitor. Drugs like ramipril, lisinopril, perindopril. Angiotensin 2 receptor blocker, ARB, is drugs like candesartan, losartan. That's the A part. So that's this bit's a little bit controversial. First line for people under the age of 55, if they're of Caucasian. C stands for calcium channel blocker, which is things like amlodipine, nifedipine. That's second line if you're Caucasian, under 55, or if you're Afro, that tends to be first line in Afro-Caribbean populations. There is some medical debate about this. And then the third line drug, which you would be offered, is a diuretic, which might be indapamide, sometimes bendroflumethiazide. How am I doing for time? Is it okay?
You're good, yeah.
Okay, all right. So just some ways in which lifestyle modification, some things which can be done with lifestyle modification. So for the risk factor of excess dietary salt, you can reduce your salt to a teaspoon a day, any added salt. For poor diet and obesity, which I may explain a bit more later, if you're found to be obese, so from medical terms, obesity is a body mass index of 30 or greater. How to explain body mass index, it's basically your height divided by your weight. Okay. And if it's above 30, there's like apps on your phone that can do it. You can go into NHS choices, and if you put body mass index, and you can plug in your height and weight usually it's in kilograms and centimeters, it will give you your body mass index. But if you was found to be obese, so that's to have a BMI over 30, you would be advised to reduce your weight by about 5 to 10%. Reducing alcohol consumption to sort of healthy levels, which is considered to be 14 units a week. Okay. For men and women. Lack of physical activity, you're aiming for 150 minutes, which kind of breaks down to about 30 minutes a day for 5 days a week of moderate intensity physical activity. Reducing mental health and stress, It's yoga, mindfulness, meditation, maybe sort of seeking counseling help if you've got a very stressful, if it's a very stressful time in your life. Okay, further ways to reduce salt intake, eat less processed food. It's just that usually during the sort of processing, salt is added and because it's also used as a preservative. Cook with little or no added salt. Use herbs and spices to flavor food instead of salt. Ways to become more active. You can speak to your social prescriber if you live in England. Basically, social prescribers, they're kind of link workers who may be able to tell you things like diet groups that are available in your area, exercise possibilities that are available in your area, may be able to speak to you about give you sort of personal sort of lifestyle targets to achieve and give you support in achieving that. Take up sport, gardening or cycling. Try walk and talk groups. There's a walk and talk movement, which would have the two things, reducing stress, hopefully, and getting you more active. Park run, which I'm going to explain a bit later. There's online yoga and aerobic classes. So this is about social prescribing. Don't medicalize exercise. Park run, it's an international organization in about 22 countries, but I think the only countries in Africa are South Africa, Zimbabwe, and one other African country, but it's in America, it's in Australia. And basically it's a timed run of 5 kilometers. Uncontrolled hypertension, which would be classed as having a blood pressure that is persistently greater than 140/90, can have complications. So complications for the heart would be myocardial infarction, commonly known as a heart attack, heart failure, so where your heart doesn't it doesn't contract as well as it should do, atrial fibrillation, angina, left ventricular hypertrophy. Left ventricular hypertrophy, you've got 4 chambers in your heart, 2 upper ones, which are known as the atria, and 2 lower ones, which are known as the ventricles. Left ventricular hypertrophy is when the left lower chamber of the heart becomes enlarged. And sometimes when it's enlarged, it doesn't pump as well. The complications of persistent hypertension on your brain can be stroke, transient ischemic attack, and dementia. My colleague who's going to talk after me, will speak about stroke. The complications, the other organs that can be affected by hypertension are your kidneys, the flow to your lower limbs, and your eyes, which it can cause blindness in some cases. So in summary, high blood pressure would be a blood pressure which is greater than 140/90 in a healthcare setting, or ambulatory blood pressure or home blood pressure, which is greater than 135/85. Lifestyle modifications can help to prevent and control blood pressure. Complications of hypertension include stroke. They're the references quickly. And thank you for listening.
Oh, great. Thank you so much. Thank you, Adra. It's a very interesting issue, and little is said about it within ourselves, just like what we've been doing with diabetes and the rest. I'm hoping that my audience will please note down your questions, and then we'll come back to you once we finish with Doris' presentation on stroke, because one thing leads to the other. So at this point, I will welcome Doris to take us through what stroke is. How does it come about? Is it related to blood pressure and hypertension, or is it an isolated instance? You are the one that can guide us through. What do you see every day at the emergency unit? Thank you.
Thank you too. Good evening, everybody.
Evening.
Thank you, Ajua. I will say a big thank you to the organizers for giving us this platform to do this presentation. I would like to share my screen. Can everyone see my screen, please?
Yes. If you can enlarge it from the beginning where you are now. Yeah. Great.
So my name is Doris Berger. I'm a registered general nurse. Currently, I work as emergency nurse practitioner in one of the urgent treatment centers in Southeast London. The aims of my presentation are definition of stroke, causes of stroke, signs and symptoms, types of stroke, and how to manage and prevent stroke. By the end of this presentation, my objectives are that everyone here will be able to identify common causes of stroke, be able to identify the risk factors, the signs and symptoms, identify complications of stroke, and be able to recognize a person having a stroke using the FAST acronym. Before I touch on the definition for stroke, I would like to give a brief introduction about stroke. Stroke is a brain attack and it's a serious life-threatening medical condition. It can happen at any age and to anyone, even babies, although they are more common in older people. Some people are able to make full recovery, but in other people, it is very fatal. So rapid response is very vital. The quicker you take somebody suffering from stroke to the hospital, the better the outcome of the recovery. When stroke strikes a person, time is very critical. Now, what is stroke? Stroke occurs when blood supply in the brain is interrupted. A clot or blood in one of the, and forms a clot or bleeding in one of the blood vessels. This causes the brain to be damaged, or it will die. There will be no activity. So in stroke, blood is supposed to flow in our brain. But when there is a blockage or an interruption in the flow of the blood, this can be due to a clot, or the stroke can occur due to bleeding in one of the vessels in a particular area of the brain. And when this happens in bleeding, there is blood in that particular area of the brain. And this part of the brain becomes disabled. There's no supply of oxygen and nutrient to the brain. So the brain cells in that area are damaged or they die. Blockage to the brain is a lot common in people than bleeding, but both of them have the same symptoms. There are two types of stroke. As I said in the definition, one of them is caused by a stroke, by a blockage, and the other one is caused by bleeding. So the two main types of stroke is ischemic stroke and hemorrhagic stroke. Ischemic stroke is caused by a blood clot, which blocks the blood vessel from supplying blood to the brain. These are more common and account for 85% of all cases. With hemorrhagic stroke, there is blood flowing into the brain, but one of the vessels in there is weakened. So the blood vessel will rupture. Therefore, there will be bleeding in and around that area of the brain. So these are the two types of stroke. One is caused by a blockage due to a clot formation, and the other one is caused by bleeding, rupture of a vessel, which leads to bleeding in that area of the brain that is affecting. Hemorrhagic stroke affects 15%, whilst ischemic stroke affects 85% of people. So as we can all see, the ischemic stroke, the one that is caused by a blockage, is very, very, very common. But the hemorrhagic one is also there, but only small amount of people suffer from it. There is another type of stroke. Before I go to that, I will explain further with these images the two strokes I spoke about, the ischemic stroke and the hemorrhagic stroke. As we can all see, if you can see my cursor, this arrow is pointing to this side of the brain. There is a brain attack there. Oxygen and nutrients is not able to get to that part of the brain. So it is the artery is enlarged here. As you can see, there are fatty deposits which are known as plaque in the artery, and blood cannot flow through it. These fatty particles, they can break and loosen themselves up and form into clots. And when they form into clots, they block the blood vessel from supplying blood into the other parts of the brain. So in this case, this is how ischemic stroke occurs. With hemorrhagic stroke, there's good supply of blood, but one of the blood vessels is weakened. And when that happens, there is a rupture of the blood vessels. So there is bleeding. There's bleeding in and around that part of the brain. And it is a medical emergency. This person needs to be sent, both of them need to seek medical attention as soon as possible. The quicker you get to hospital, the better the outcome. There is another type of stroke known as transient ischemic attack, abbreviated as TIA or mini stroke. It's a type of stroke that the symptoms last for few minutes or up to 24 hours. They are warning signs that someone is at a high risk of getting a stroke. So both are very, very important. There are some early warning signs before a stroke strikes somebody. There are early warning signs. We have dizziness, headache, weakness, confusion. To add to what I have on my slide, some people will complain of blurred vision or loss of vision in one eye or both eyes. Some will have repeated vomiting. Some people will complain of numbness on one side of the face or one side of the body. It can be the hand, the leg, or the foot. So these are the warning signs. Stroke has some cardinal signs. So if you call ambulance, that you make your complaint, which is likely to be a stroke. These are the cardinal signs that the ambulance crew will use to assess you. And this is where they will say you are fast positive or fast negative. If they say you are positive, then for sure you have the stroke. So, and then when you come to A&E, we also use this to assess in addition to other investigations. It will be very good for all of us to be able to remember the FAST acronym. F stands for face dropping to one side. A stands for arm weakness. S stands for sledge speech. T is time critical. That is the time. If you see any of these signs, any of these signs in your neighbor, your friend, your family member, that is when you have to call the ambulance. Because the earlier you get to hospital, I'll continue saying this, the better the outcome. I have some images here for how to spot a stroke. In this lady, you can see the facial droop. The face is dropping to one side. This man's arm, there is some weakness. He cannot lift it up. This lady is trying to say something, but she's finding it very, very difficult. She's like speaking gibberish. You cannot understand what she's saying. This is the time to call ambulance. This is the time to take the person to hospital. So you call 999 and they will come and take this person to the hospital. There are some medical risk factors that lead to someone getting a stroke. Medical conditions like high blood pressure, high cholesterol, irregular heartbeats, diabetes, obesity or overweight, smoking, lack of exercise, excess alcohol intake, birth control pills, family history, age, and a history of TIA. I also have a graph to explain how stroke cases affect some age groups and gender. So horizontally, I have the age group, and vertically, the percentage of cases. The blue color is for percentage of male cases, and the red is for the percentage of female cases. As we can all see from this graph, sorry, anytime that I touch it, it moves to the next slide. From age 50 to 59, we can all see that the percentage of cases in the male is about 20%, and in the female is 15%. From age 60 to 68, the percentage of stroke in male cases is about 30%, very high, and in the female is 25%. When it goes to age between 70 and 78, it changes. It is high in the female, about 25%, and 20% in the men. It has dropped. From 80 years and above, the percentage of stroke in the men is about 15%. It has dropped down. And with the female cases, it has increased to about 20%. So this is the graph for stroke, age, and gender. According to statistics, stroke strikes every 5 minutes. So every 5 minutes, there is somebody somewhere suffering from stroke. That is why it is a very serious, life-threatening medical condition. And each year, 100,000 people have a stroke. Stroke survivors in the UK is said to be approximately 1.3 million. In 2016, stroke affected 57,000 people in England, with 51% in males and 49% in females. People with African, Caribbean, or South Asian background have higher predisposition to diabetes, high cholesterol, and high blood pressure. These underlying medical conditions greatly increase stroke in the ethnic group. So we have to try and prevent this stroke. Now, before somebody is being diagnosed, a lot of investigations are being done, and these investigations lead to the diagnosis. There's a physical examination that is done. The patient's blood pressure, pulse, saturation, oxygen level, and temperature will be checked. Also, the doctor will listen to the heart, and they will do a neurological examination that is when they will use the FAST acronym. Also, blood test is done. This is where they will check your clotting level. Your blood sugar will be checked, whether it is high or low. Your cholesterol level will be checked, and also the blood test will be checking if you have any infection. CT scan is also done. Here, a dye is injected into the blood vessels, and it will be able to show during the scan that whether your stroke is the type that you've got this stroke due to a blockage or due to bleeding. MRI also does the same thing. They will inject a dye into the blood vessels, which gives a clear view of the arteries and the veins, and it also highlights how the blood is flowing in the brain. It does the same thing, similar thing as the CT scan. It will also show whether there is a blockage by a clot somewhere in your brain, or there is a bleeding somewhere in the brain. They also do something called carotid ultrasound. In our neck, we have a very large artery. And so they do this, which is called the carotid artery. So they do this scan to check if there are any fatty deposits in the artery, because it can break loose and form a clot and travel into the brain. And when they enter the brain, they will dislodge themselves somewhere and stop this, the circulation of blood. As I said, there will be a blockage. So in that case, that person will be suffering from a stroke. Echocardiogram is also one of the investigations that they do if somebody comes with signs and symptoms of stroke. The doctor will look at your lungs. They want to see the source of the clot. So they want to see if there was any clot in your lungs, which is known as pulmonary embolism, that has traveled into your brain. So sometimes they do all these things to find the source. Why is this person having a blockage or interruption of blood circulating in the brain to nourish the brain tissues? So out of these investigations, the doctors are able to diagnose that A is suffering from a stroke called ischemic or hemorrhagic. Ischemic because there is a blockage due to a clot in the brain, or hemorrhagic because one of the vessels have ruptured and there is bleeding inside the brain. So this is how stroke is diagnosed. When it comes to treatments, it depends on the type of stroke you have, which part of the brain is affected, and what caused the stroke. So if the blockage is on the right side of your brain, the weakness will be on the left side. And if the blockage is on the left side, then the weakness will be on the right side. So if, for instance, your stroke is due to ischemic stroke, there is a strong blood thinner called alteplase that is given to dissolve the blood clots. They also give medications to reduce blood pressure and high cholesterol, including diabetes. If your stroke is hemorrhagic, that is, if your stroke is caused by rupture of a blood vessel and there is bleeding in the brain, in one particular part of the brain, surgery will have to be done to treat it. So they will put in a wire to drain every blood that is in there, and then they will put in a stent. This is to reduce the risk of further bleeding. So this is how stroke is being treated. Now, how do we prevent stroke? There are so many ways that we can prevent stroke. One of them is eating healthy. We have to eat a lot of vegetables, a lot of fruits, a lot of fish, less chicken, less red meat. We have to do a lot of exercises. So my colleague spoke about this and I'm hammering on it again. It's very important. Exercise 30 minutes per day is very, very important. We have to control our cholesterol, eat low-fat foods, manage our diabetes, visiting your GP regularly for blood tests, and also, if possible, checking your blood sugar at home. Quit smoking, reduce alcohol intake, treat high blood pressure. If you are diagnosed as suffering from blood pressure, it is very, very important you take your medication. You visit the GP when you are being booked to come for checkup. And also, if possible, try and monitor your blood pressure at home. It's very, very important. If we all try to do this, a lot of people will be saved from getting stroke. Now, there is a lot of mental effects of stroke on our relatives, our loved ones, our neighbors, and even the family themselves. Mentally, they suffer due to a family member having stroke. The patient or our loved one always have a feeling of irritability or anger. They are forgetful, they are confused, they become anxious and depressed. Why? Because before, Mr. A or Mrs. A was able to do things independently. Then suddenly you have a brain attack. You are not able to do things for yourself. You become dependent on people. You can't speak. You want to tell a family member something. You are not able to express yourself. So it makes them become frustrated and anxious. Socially, they are isolated. Most of them are not able, most of the people suffering from stroke find it difficult to go out. Most of the time, they will need somebody to take them out. If they are able to sit down, then they have to put them in a wheelchair. You know, these are people who used to socialize a lot, and at this stage, they cannot. So this also contributes to their feeling of anger, anxiety, and depression. There are also relationship problems. You know, there is sexual dysfunctioning, and it's difficult for the partner to talk about it because you have to stay strong for the one who is suffering from the stroke. So it is very good for those who are taking care of their loved ones or relatives or neighbors suffering from stroke to have a break. It will be good if you get somebody around to be helping you. Go for a walk, watch the telly, read something, have a break away from the care, and mentally, with time, you will improve. These are my references. In summary, stroke occurs when the blood supply to the brain is reduced or interrupted or blocked completely, preventing the brain tissue from getting oxygen and nutrients. Ischemic stroke and hemorrhagic stroke are the two main types of stroke. CT scan of the head and MRI is used to diagnose stroke. Be fast when you suspect a person is having a stroke. Remember to use the FAST acronym. So, from what I have said, we can all know why stroke is a serious medical condition. It is life-threatening. And as I said, there are two types of stroke, one that is caused by a blockage and one that is caused by bleeding. This is the end of my presentation. Thank you for your kind attention. Now is the time for your questions. Thank you.
Thank you so much, Doris. Thank you. You and Adjo, you know, one of the things I love about GNA and your team is that they are good. They have this good education team, and everybody knows what they are talking about, and so it's so interesting because they come with the experience, the knowledge, and everything else. We couldn't be grateful. But for us to have a little bit of mind away from whatever we've heard and take a cup of water or something, we'll give ourselves a few minute break, and we'll come back for your Q&A. Please raise your hand using the icon so we can call you. I have a few questions that I may start with, and then I will lead on to the others. So the earlier you put your hand, the better chance that you'll be your hand will be called up for your question. We'll be back shortly. Thank you.
Welcome to BWF Solicitors, a trusted and experienced family law firm specializing in immigration and naturalization, as well as dispute resolution. Meet Bernard Owusu, our esteemed senior partner with over 30 years of experience and known for his expertise and dedication to serving our clients in the community. BWF Solicitors stand for integrity, respect, excellence, teamwork, diversity and inclusion, and service to the community. We provide tailored assistance across all areas of UK and Ghana law. At BWF Solicitors, every day is filled with dedication, creativity, and a commitment to finding the best solutions for our clients. Led by experienced senior partner Bernard Owusu, the team at BWF Solicitors is ready to assist you with your immigration, naturalization, dispute resolution, family law, new wills and probate, Ghana law and practice needs. We are dedicated to providing solutions to our clients' problems. You can find us at the 4th floor, Anna House, 214 to 218 High Road, Seven Sisters, London, N15 4NP. Main office line 0208 493 7340 or our emergency line 07712 761 884.
Welcome back. Welcome back to this forum, which in the past hour we've been discussing. We've been talking about our experts. You can have them on the screen with me, please. They've been taking us through hypertension and, of course, stroke. Two main killers that apparently is the risk factor indicate that. So those of us in the African community, Caribbean, we do suffer a lot from it. And therefore, a lot of these ideas that they've shared with us or information they've shared with us can help us. It can help you manage someone you are looking after, can help you manage yourself and family and friends and loved ones. Thank you, Adjoa Banahine, and thank you, Doris, for bringing this information to us. Your presentation are excellent. Well done. You've made all of us proud and GNA very proud. This program is put together by Ghana Union in conjunction with Ghana Nurses Association, the education team. Well done for doing that for your people and the community you serve. As you say, you serve and you care. Yes, now I remember that one. I have two we serve groups, so I tend to get confused. One says we serve with passion, one says we serve and we care. Yours is to care. Okay, so thank you. Q&A sessions, please. I'm going to ask 2 questions, and then I've seen some hands up. Those who want to ask questions, please raise your hand so we can call you. Regarding hypertension, I have a basic question. Why is it that the later women get it later in life at the age of 60, while men tend to have it from, say, 40?
I think it might be the effect of hormones,
right,
later in life after you've had the menopause, so that's why.
Okay. Is it also that could it be that women tend to look after themselves a bit more than men, apart from the hormonal changes?
Think, but the thing is, women would seek help earlier.
Right. Yes.
They definitely it's usually men have to be strongly or gently encouraged to seek help and monitoring.
I think you're right. I think that is true. A woman's nail will fall, hair will fall down, the whole world here, right? Men, we will keep it forever until we're about to drop. I think that is true. That is true. Okay, on the other side of the divide, you talked about stroke. Again, it tells me that between the age and gender gaps, so one gender tends to have it, and then as you get older, it starts to drop. Why is that? Because from the analysis, from the presentation, I realized that those above 70 plus, then they start having the likelihood of having it drops for those age categories. Is that, and obviously
This
in
is
terms
due
of gender.
to lifestyle changes. You know, most men like smoking, drinking, and other things add up to that. Although women also have this lifestyle. But at the age that it increased in women is because of pregnancy, long life expectancy, hormonal medications, all play parts in raising stroke in women's life. So that is why.
Okay. All right. I'll go back to those two hands up and then I'll come back if I have more questions. If I may call Felix, please. Felix Bar.
Okay.
If you can unmute yourself.
Good evening. I'm Felix Bar. I'm in the Netherlands. I have about 3 questions.
You're from where? The Netherlands?
The Netherlands, yeah.
Okay.
First of all, in between the hypertension and the stroke, there is heart attack. So where do you situate heart attack?
Okay. Can I answer that? Oh, have you finished?
I have 3 questions. Maybe I can finish my questions, or you want to answer them one after the other. Okay, go ahead.
Maybe jot down the questions, the panelists, if you can jot down the questions, and then once you finish, you can take it instead of one after the other. Felix, if you can continue.
Okay, and also looking at the graph of percentage cases of stroke against age, we see that after the age of between the 60 up to 60, 67, there is a rising, trend. And then afterwards it's dropped down. Is it because, well, if you look at the life expectancy, world, life expectancy is somewhere around 70 years. So is it because of the fact that after that, maybe people have died of other causes other than, that is why this is going down. And then my third question is about the prevalence of among Africans, Caribbeans, and the South Asians. Is there anything that is common between these groups that makes it that with this ethnic groups is more prevalent among them in terms of stroke?
Okay, thank you. I'm hoping you've got the questions.
Okay.
All right. Okay. So you can.
Shall I answer the first question?
Yes, please go ahead.
And Doris, can you answer the second one, and I'll answer the third one. So for the first question, it just I'm recapping to check that I've got it right. You said in between hypertension, you said there's heart attack and stroke. Is that what you said?
He said in between hypertension and stroke, there is heart attack. Where does heart attack sit in between those two?
Okay, right. Well, basically, you've got there's hypertension, and hypertension can be a precursor or come before a stroke or before a heart attack. So the person who has hypertension, if they're really unlucky, could have a stroke, and they could also have a heart attack. And it may not be one after the other. And it's basically, I don't know if you can see. So like if you've got your blood vessel and the blood's flowing through like that, in hypertension, it's likely to be less because can you see my hand? There's less space for it to go through.
Yeah.
So if you think the blood vessels supply muscles, so your brain is one muscle, your heart is another. And if you've got reduced blood supply to that muscle, it can get damaged. Either way, in either sort of supply, you could get a clot. So if there's a clot in the brain, it's a stroke. If there's a clot in the heart, it's a heart attack. And then the muscle, which is behind the branch being supplied, dies. Does that answer your question?
Yeah, hopefully. I think we've got the
Yes,
analysis.
it does. It answered the question.
Okay. Any of you can take the remaining two to still
So
remember.
the second question regarding the age, the gender, and the percentage, I think you answered the question briefly. You part answered it. So between the age 60 to 67, there are other conditions that that person may be predisposed to before having the stroke. And with men, as we said earlier on, they don't care, excuse me to use the word, they don't seek medical help on time. They wait till the last minute. So that is why at that age, you could see that it is high among the men than the women. Have I answered your question?
Yes. Okay. Felix, are you okay with the answers that we've got for that one? I think
You are
it's fine.
muted.
It's muted, but it's fine. I'm sure you'll come back again if he's not clear with it. If you've got another third question which he asked.
And could he just repeat the third question? I think I can answer it, but can he just refresh me on it?
The question was how because this stroke and hypertension is more prevalent among Africans, Caribbeans, and South Asians. And my question was, is there anything common among these groups that makes that leads to this conclusion?
Okay. Well, the conclusion, the conclusion is kind of the sort of hypertension being more common amongst Afro-Caribbeans and Asians. It's basically because they just done research and then like epidemiological studies, and they find the incidence is higher. The stroke being more common is because they have the predisposing conditions, which is the diabetes, hypertension, obesity. So that's why the stroke's more common. Hypertension, I believe, sometimes may be due to the salt in the diet. Why it's one reason why it's more common amongst Afro-Caribbeans. There may be other causes which I'm not fully aware of.
To add to what Ajua just said, a research was done why it was common in that ethnic group. They realized that most of them did not, and it was language barrier due to communication. So now they have to formulate leaflets that is in their language. And then they started getting interpreters that will interpret to them what stroke is or what blood pressure is, how to prevent it, and if you are already diagnosed as having one, what you have to do. So I think now with the current research that will be coming out, it should be low.
Why should African living in Africa have a language barrier, and why would language
Not
barrier
Africans, the Afro-Caribbeans and other nationalities, where you will be surprised that there are some people in Africa who doesn't understand what is going on with high blood pressure and high BP and stroke. Some, we are all Christians, but some tend not to budge down to medication. They prefer to pray and pray and pray, and that will not solve it.
Okay,
You
I
have
understand.
to take the medication with it.
I think my brother,
It's more education than language.
yeah,
Correct.
you'll be more aware of the fact that our people back in Africa, where Ghana, we resort to remedies that are not what is it called? Certified. Praying, being in 24-hour church, 7-day fasting, when you know you need to take your medication. Somebody saying that your grandmother is killing you when you know your blood pressure is rising all the time. You're not eating well. So these are the reasons why I believe it's add to the evidence out there, I think. because
There was a case in the Netherlands, a lady, and she passed away. The husband, because of their church, how to ask her to stop how to call it, medication. And after some time, one time she was just climbing the steps, and then she just fell and didn't survive.
Yes. Of course, by all means, we are not saying ignore your faith, but use common sense when it comes to your health.
Yeah.
There's a reason why these medications and these people go many years of study to help us manage it. So that is a matter for thought for all of us. But also, while you are in Netherlands, when you get the flyer, share it with people that you know, your contacts, so they can also join. It's nice to have people also joining from other parts of Europe and the world. Thank you for being here. May I call Elizabeth Hackman, please? You can unmute yourself. Thank you.
Good evening, and thank you, Ajua and Doris, for a concise presentation. I think what I was going to ask is the age difference towards the end, that the stroke percentage in women is raised from the age of 70 onwards. But I think, you've answered that, unless you want to add something else, because it seems to be quite a great jump from where we start from. Okay, thank you.
Thank you. So from me, it seems that by the time the wife will get it, the husband is already got it and maybe on his way out. That's probably why we die quicker earlier in most marriages than the other part, which is good. It's always good to see our wives living with the children and we gone. But it means that we also need to take care of ourselves. Doris, and do you have anything to add to that or not? From what happened? Okay. Florence, please. Florence again. You can unmute yourself, please.
Okay.
Thank
Right.
you.
What I wanted to add to my colleagues is that regarding the diet, in Africa, the way we cook, we put in Maggi cube, we add this to make the food so nice and it's all salty. And also, secondly, we eat late. We listen to friends, what they've been using with their medication. Oh, I was given this type of medication that helps, but not everything that suits everybody. So we need to be very compliant with what we do, especially in Africa or any other countries. We need particular about our medication that prescribed. What is prescribed for an individual person, it's not for the other person, because you don't know other precondition that the person may have, and you also have to have that the same medication. So I'm centering on our diet particularly, because we get to work late and then we go back home late, and that also affects our way of living. And we eat the same food at the same time, midnight, we're eating the same food, if it's a big bowl of whatever, because you are tired. And that also predisposes all these conditions coming to us. And we want to make the food as it's tasted how your mom used to cook in Africa. It's not so. We have to start adopting a way of living in another country and modify the changes, and also educate our fellow Ghanaian or other communities that the way of eating has to change, because things are changing the whole world. We're doing different things. So our diet is more particular to what we are discussing today. I just want to add to my colleagues what they've been saying. And I appreciate what you've done. Thank you.
Thank you so much. Thank you. That's very important. These days, a lot of what we eat, especially as I'm sure most of you will, a lot of what we eat are processed food. We don't have any originality of any type of food that we eat. So I think what Antipolis is saying is a good one, because it is what goes into you that defiles you. And once you get there, it does a lot of damage gradually. So I think the diet bit, because for the past couple of months, we've been doing this series on health with GNA. Seems like all the issues that we've addressed, from diabetes to hypertension to stroke to all the other bits that we've done, they all tend to have a common management style in terms of exercise, in terms of good food, healthy eating and all that. So I think the common theme is that we need to just be good at looking after ourselves well. If I can call Professor P.K. Richardson, and I'll come back to Felix, please. P.K. Richardson, please. If you can unmute yourself, sir.
Right. Thank you. Good evening, Joe and Doris, and for a wonderful time this evening, and Nana for always putting these things up. They do say, don't they, that knowledge is power. And what we've heard today, if we're all going to take it in, abide by it, and use it, it will, in no small way, enhance the quality of life that all of us can enjoy. So thank you very much. And I always look forward to hearing from you about these things coming up. Thank you. Thank you.
Thank you, Prof. Thank you so much for your encouragement. It's always nice to have people watching and listening and also supporting us in this work. Some people don't see any reason why we should do it, but we've got about 60 people joining. 60 can tell other 60 people, and those others can tell other 60 people. It's a great number, and we are making progress with our community. Felix, you're back with your hand, please. Do you want to ask anything else? Mr. Ban? Yes,
I wanted to, how we call it, it's about these preventive measures. We mentioned processed food. And I don't know if there is any malnutritionist among us who can give a definition of processed food, because I think our ladies spend a lot of time in cooking, and could that be an issue? I just wanted to know if there is someone what a processed food is, and how can you prevent this in our meals, in our cooking?
I can shed some light, not completely, some light. So processed food is things, sometimes it's canned foods, okay? Sometimes it's like meats that have been modified. So things like sausages, beef burgers, they're like the ready meals, they're all processed food and so how to change it in your diet is to eat kind of fresh food. And the problem is people eat processed foods because it's quicker. And in today's modern life, you probably haven't got much time to be spending cooking, in addition to maybe going to work, looking after the children, looking after an elderly relative. So that's why. But the processed food is the food that's been modified. And so to get away from that is to try to eat fresh food or some frozen food. So fresh fruit and vegetables. So Felix, are you still there or not?
Yeah,
so the advice would be to eat 5 portions of fruit and vegetables a day, of which one should be a juice. But then things like so if you had 2 portions of vegetables with each meal, then you'd get in your plus like a juice or a fruit as a snack, then you'd get in your 5 portions of fruit and vegetables. So that's one thing. And just like so, and things like, sometimes some like the whole food. So like if you're going for more brown rice, because it's less modified than like white rice. And then you'd have to look this up online, but there's things like low GI index foods, which they're foods that are nearer to the natural source and they take longer to break down. So that's the thing. But so it's food that's been modified, particularly the meats. So sausages, burgers. I'm trying to think of other stuff that comes off the top of my head, because they usually add some either fat, salt, or sugar in the process to preserve them.
Thank you. Somebody put it here saying that to add to address, blood pressure can be taken on the legs, particularly dialysis people. Again, in addition, 24 hours, there is 48 hours and 72-hour monitoring. I think somebody was just, Adriel Lamte was just trying to contribute to the fact that the pressure can be taken for those with dialysis on dialysis, they can be taken from the leg. I don't know how that works. Is this something
Okay.
we can?
I can explain.
Yeah.
So basically, how the blood pressure is taken is there's a cuff, but inside the cuff there's a bladder which inflates. And that can be wrapped around an arm, it can actually be wrapped around a wrist, it can be wrapped around a leg, it can be wrapped around a thigh. People who have dialysis have like a special tube in their arm called a shunt, and you can't take the blood pressure in that arm. But some people may have exhausted one and two arms. So the same cuff that is wrapped around your upper arm, I don't know if I can go back. Can you remember the picture of the person having their blood pressure taken, and you saw it was like a beige cuff, a grey cuff around their arm?
Yeah.
That cuff or a different size cuff can be wrapped around somebody's lower leg, just above their ankle, or you can get ones that go around the thigh as well.
All right.
You can take the blood pressure in different places in your body.
Okay. Well, we seem to have no hands up. Is there anyone who has something to ask? Because that tells me that at least all of us have got the information and we are okay with it, happy with it, and that will lead us to bring it to a close, which will be great for Friday evening. Is there anyone? Albert Cranting. If you want to ask a question, we've got 30 more minutes. Please, let's make use of the time and respect the people that are here so that we can get information. Albert, if you can unmute yourself, please.
Hello, good evening, and thank you very much, ladies, for your very beautiful presentation, which has shed a lot of light on what I've been thinking about stroke and hypertension. My petty question is, for preventive purposes, I have on my own blood pressure monitor at home. But the question I want to know is, on which arm does one have to take this reading? Because when I go to my doctor, depending on how I sit, he takes it on my right arm. When I go to a CNS, he takes it on the left arm. I tend to take it both at home, and they give different readings.
Okay.
Which is the best arm to take? Is it because of the heart related to the left arm?
No, I can answer that question. Basically, what you're supposed to do, the kind of instructions is initially you're supposed to take it on both arms. If the difference between arms is less than 10 millimeters of mercury, it doesn't matter which arm you take it in. If it's greater than 10 millimeters of mercury, you're supposed to take it in the arm that the blood pressure is higher. That's the answer to that question. So it's not whether it's left or right, it's the arm that the blood pressure is higher in.
Thank you. I've also noticed that sometimes when you take it yourself, it tends to jump and even makes you even more worried. And then you walk to your GP and it doesn't show as much as you did it yourself. Why is that? Because I used to measure my one and I've now given up on it because anytime I measure it just shoots up to heaven. And then I go to the doctor and he said, you're fine.
Okay, right. I can answer that again. Right. So blood pressure is affected by number one, it changes. So it doesn't always stay the same. It changes over time, and the changes can be dependent on emotion.
Mm-hmm.
Well, three basic things. There are some other things, but the basic things are emotion, activity, and hydration status. They're the three basics, but there are others. So if you so that's why you should kind of be sitting for about 5 minutes before you take it, not having had cigarettes. Caffeine drinks can temporarily increase it. Sometimes the medication can temporarily increase it. But if you're anxious, because when you're anxious, sometimes you can send out chemical messengers in your body, and that can constrict your blood vessels, your blood pressure can go up. So that's why sometimes if you take it at home, it may jump. But if you try and also talking can affect the reading on the automated machines as well. So that's why you need to sit quiet still for about 5 minutes and then take your blood pressure, and it will be okay in most cases.
Okay. Someone put a message on the chat saying, how do you determine
Okay.
the best medication for hypertension? How
Right.
do you determine the best
Oh,
medication
the
for
best
hypertension?
right, how the medication is the best medication for hypertension. It's not, it's basically what would bring your blood pressure down to say like within sort of normal levels. So you'd be aiming for a blood pressure below 140/90. That's not going to give you any adverse effects. So if it does that, then it's a good medication for you. So it's not necessarily that one medication may be good for one person, but not good for another person.
Right.
And just to add that once you've been diagnosed with high blood pressure and you are on medication, you do need ongoing monitoring. And even if you're not on medication, you probably need ongoing monitoring, which is basically having your blood pressure taken at the surgery at least once a year, maybe more frequent if it's found to be high.
Right. So what do you advise, so especially for men who have the belief that these medications suppress their sexual activeness?
Okay,
Because
I've got an answer for that as well.
a lot of men don't take them
No,
because
I've
they think it will render
no,
them useless.
no, I've got an answer for that. Basically, they used to prescribe beta blockers for hypertension, and beta blockers were associated with impotence in some cases. So they don't tend to prescribe beta block. There's other reasons as well that whereas they don't tend to prescribe beta blockers. They're asked for hypertension. So the standard is A, ACE inhibitor, C, calcium channel blocker, D, diuretic. Sometimes if your blood pressure is resistant to all three of those medications, then you may be prescribed a beta blocker, but it tends to be in secondary care. And also sometimes untreated hypertension and uncontrolled diabetes can also have that effect on your body. So it's better to get the blood pressure and diabetes controlled if you have it.
I see. Okay. Someone is asking when your blood pressure sometimes is higher. Okay, so how many times should you take BPG to get the correct readings? So sometimes you take it and you see it's higher.
Okay.
How many times? On what?
Right.
Let's say an average of 3 or 4 readings. Which one should you take?
Okay. Can I answer that, Doris?
Yes, it's fine.
Can I go ahead and answer that?
Yeah.
Right. Basically, the advice is, and say like what we're trained to do is to take 3 readings and you take the lowest out of the 3. 3 readings with the person resting with their arms supported at heart level and the cuffs at heart level.
Right. Okay.
And always make sure you keep record of it.
Okay.
Yeah.
Okay.
Um,
Yeah, I'll go ahead. For the other hands.
call the other hands.
Okay. Albert Quentin, your hand is up again. Do you have something else to add?
Yes. I just wanted to know what your experts will recommend, i.e., the conventional pharmaceutical drugs as against our traditional herbs that we use at home, because there's all these always the advertising in Ghana and all that thing about the natural herbs that we have reducing blood pressure with no side effects. What do you say about that?
I think this depends on the individual. There are some people who would like to just strictly take the medications they are given, and there are others who would like to combine both, which is not the best, because if you're having a side effect, how will you know? So we have to be careful. I'm not saying it's not good. Some of them are very, very good, but be careful of what you take and how you take it. Ajwa, do you want to add something?
I've got something to add. So
Yes.
Albert, what I would say is, if you I would probably steer the reason why they usually say the conventional treatment is basically because it's been researched. So they've been done like trials that have shown that if it's given to 1,000 people, like 950 people, it will lower its blood pressure without having any adverse effects. So that's number one. Number two, if you're taking the herbal medicine, are you monitoring your blood pressure at the same time to know that your blood pressure has come down? And that is probably the key thing, is the monitoring, to know that your blood pressure has come down, and to have the monitoring to know that if you're taking the herbal medicine alone, that you know that your blood pressure has come down and your blood pressure has not affected. You don't have any of the other potential complications of blood pressure. And I would also add into that, in a way, the best treatment is the lifestyle changes, if you can actually do it. If you can do the lifestyle changes, which is very, very hard work, there is a slim possibility that you could come off the medication. So just to elaborate, in the surgery that I work, there's about 1,500 people with high blood pressure taking medication. Of those 1,500, possibly about 100 have managed to come off medication, but the 100 that have managed to come off medication have lost weight. So something like you was 90 kilograms and you come down to 80. Okay, they work hard at their exercise. So in what I'm saying, in working hard at their exercise, they would have possibly a recreational activity that has exercise that they would do at least once a week. They would make sure that they're sort of walking regularly, possibly giving up smoking, possibly giving up drinking, and have adjusted their diet and stuck to it. So it's possible. It's the possibility is slim, but it's hard work. But if you could do the lifestyle changes, that's number one.
Right.
That's it from me.
Okay. Felix, please, your hand is up. You want to unmute yourself.
Yeah, my how to call it? It's a question about insulin resistance and nitric oxide production in the body. How does this influence blood pressure?
Okay, I think I can kind of answer that, but basically, when you have insulin resistance, you have a tendency to put on weight. And also, so it's a kind of metabolic condition. So you have a tendency to put on weight. So you don't burn calories as much. The insulin that your body is producing is less effective. And then that can also have an effect on your blood vessels as well. So that's how. I don't know about the nitric oxide production.
It helps to dilate your arteries. So it uses it needs oxygen to to be able to produce this nitric oxide, and it's a gas that helps to dilate the.
So are you saying given as a therapeutic measure, or?
Yeah, you can. It's a gas, and so you can.
No, nitric oxide is a gas, but
it's produced by the body. The body
it's
produces,
also
but
Yes.
there are some people who where their body cannot produce sufficient, and this could eventually also lead to how do you call it, narrowing of your arteries and causing this blood pressure.
Sure. Okay.
Okay. Okay. So, Doris, if I may ask regarding those type of stroke that you discussed earlier, you said there's 15% that it's almost like a burst of blood floating through your brain. What are the chances of survival of those circumstances? Is it the same thing that we call it what is it called, brain hemorrhage or something like that? We keep hearing somebody died of brain hemorrhage and all kind of things. Is that what that's supposed to be?
Yes. So with this, we have two types. We have the subarachnoid hemorrhage and intracranial. So it can be inside or just above it, between. And both can kill. So you have to get to hospital in time, because when this happens, you get swelling, you have severe headache that you cannot explain. So you have to go to hospital. But that sort of stroke is not common. It is not common. That is why it's only 15% of people cases. Yeah.
Let's see. Okay. I am done with my questions. Is there anybody that wants to ask anything or add to anything that we've heard tonight, or make an observation that you think can help us, produce this program better than it is already? Please let us know. Ghana Union and Ghana Nurses Association, in conjunction with the Ghana High Commission, bringing you live on Zoom, Facebook, and YouTube. My name is Emmanuel Kusikwesin, also known as Nana Kusikwesin the First. Tonight, we've been talking about hypertension, stroke, and all its related issues. And my hope is that we are taking away a lot of experience and knowledge that will benefit yourself, your family, and your loved ones. Behind the scenes on this program has been Paul Akwabwa and Linda Wayo, who are bringing us this IT program that helps everybody to view it from wherever you are. We are grateful to them. Thank you so much. Is there any closing remarks you want to give us, Doris and Adjoa? Closing remarks. Any remarks you want to share with us?
What I would say is that, as I said in my objectives, that by the time we leave here, I'm expecting everybody to remember the FAST acronym. F for face dropping, A for arm weakness, S for speech difficulty, T is time to call the ambulance. And always remember that there are two types of stroke. One is a blockage caused by a clot, and the other is rupture of the blood vessel causing bleeding in the brain. They are all treatable. The earlier we get to hospital, the better the outcome. Thank you.
Thank you so much. And Adjoa, please.
Okay, I would like to say thank you for listening. There's a little bit more I've got to say. The take-home message would be that check your blood pressure. If it's high and you're prescribed medication, take the medication, but always do the lifestyle changes. Thank you.
Okay, it has been a pleasure having you all on the forum, participants and the audience, and our panelists. We are grateful for your time Friday evening. I wish you all the best. Have a good rest and enjoy the rest of your weekend. Thank you very much. Good night.
Thank you.
Thank you.
Thank you.
Welcome to BWF Solicitors, a trusted and experienced family law firm specializing in immigration and naturalization, as well as dispute resolution. Meet Bernard Owusu, our esteemed senior partner with over 30 years of experience and known for his expertise and dedication to serving our clients and the community. BWF Solicitors stand for integrity, respect, excellence, teamwork, diversity and inclusion, and service to the community. We provide tailored assistance across all areas of UK and Ghana law. At BWF Solicitors, every day is filled with dedication, creativity, and a commitment to finding the best solutions for our clients. Led by experienced senior partner Bernard Owusu, the team at BWF Solicitors is ready to assist you with your immigration, naturalization, dispute resolution, family law, new wills and probate, Ghana law and practice needs. We are dedicated to providing solutions to our clients' problems. You can find us at the 4th floor, Anna House, 214 to 218 High Road, Seven Sisters, London, N15 4NP. Main office line 0208 493 7340 or our emergency line 07712 761 884.